You'll find links to subscribe to a daily update on COVID-19 from the Johns Hopkins Center for Health Security, webinars, and a new daily podcast from the Johns Hopkins Bloomberg School of Public Health. We encourage you to check it out at coronavirus.jhu.edu. Before going further, I would like to take the opportunity to thank Congress for its swift and decisive action on passing H.R. 6074, the Coronavirus Preparedness and Response Supplemental Appropriations Act. This $8.3 billion package will fund a robust response to coronavirus, including vaccine development, support for state and local governments, and assistance for affected small businesses. And with that, I'll introduce our panel. First, Dr. Tom Inglesby. He's the director of the Johns Hopkins Center for Health Security of the Johns Hopkins Bloomberg School of Public Health. Then Dr. Lauren Gardner, co-director of the Johns Hopkins Center for System Science and Engineering. Dr. Andy Pekos, who is the co-director of the Johns Hopkins Center of Excellence in Influenza Research and Surveillance. And Dr. Lisa Maragakis, Senior Director of Infection Prevention, the Johns Hopkins Health System, and Hospital Epidemiologist at the Johns Hopkins Hospital. And finally, Dr. Jason Farley, Professor of Nursing, a nurse epidemiologist and a nurse practitioner in the Division of Infectious Diseases in the Johns Hopkins University Schools of Nursing and Medicine. I also wanted to let you know that C-SPAN is here and to take an efficient approach to our question and answer and ensure that we answer as many of your questions as possible. We'll be passing out cards for the Q&A. So if you do have a question, please write it on a card and pass it along, and we will be sure to get it back to our panelists. So we'll start with a few brief words from each of our panelists. Dr. Inglesby?
Thank you, Lauren. I was asked to say a bit about COVID-19 spread in the world and the disease, and a few points about U.S. priorities at this point. COVID-19 was first recognized in Wuhan, China, at the start of December, and in the following 2 months had grown from 1 case to more than 70,000 cases, and it spread to all 31 provinces across China. As of March 5th, the disease has been diagnosed in more than 100,000 people. We'll hear more about that from Lauren Gardner in a moment, and has killed more than 3,300. Outside of China, leading countries include South Korea, Iran, Italy, France, Germany, and the U.S. The U.S. is about 7th in terms of total cases of disease in the world. And as of March 5th, actually as of this morning, there have been approximately 215 cases in the U.S. with 14 deaths. And most importantly, 78 of those cases have no known link to known coronavirus cases. Those cases then we would consider something called community transmission, which is transmission that's occurring without an obvious link to some other case. Patients who become sick with COVID-19 have cough and fever, and in the more severe cases can develop viral pneumonia. And in the worst cases, patients develop a syndrome called ARDS, which is a severe pulmonary syndrome which mirrors the disease that was caused by SARS back in 2002, 2003. Some patients' initial symptoms can be GI symptoms, nausea, vomiting, or diarrhea. In China, approximately 80% of those with illness developed mild symptoms, not requiring hospitalization, with people recovering without any medical intervention. About 15% of cases required hospitalization of some kind, and 5% of cases required critical care. Most of those would require ventilation in the United States. It's not clear exactly how many of those patients in China did receive mechanical ventilation. The overall mortality of this disease is difficult to calculate because of the different ways we are diagnosing the disease around the world. We believe that there is a over-diagnosis or a representation of people who are the most severely ill. We find severe cases first because they're the most obvious and they're in the hospital. So that is going to skew case fatality rates or mortality rates upward. And the more that we do diagnosis, the more that we diagnose mild cases, the more that will drive down the overall case fatality rate. But it's too soon to say how far that will go. We do know that in Hubei province, the province where Wuhan city is, about 4.3% of recognized cases there have died, Again, that's not a case fatality rate. That's just a crude calculation of the number of cases that have been identified and the number of deaths. In Italy, that number is about 3.2% of cases have died. In the Republic of Korea, only about 0.6%. I don't mean to minimize that, but a lower number, 0.6% of those cases have died. And we think that that represents a much more ambitious testing strategy in the Republic of Korea. More than 140,000 people have been tested over a short period of time, which does, we think, increase the number of mild cases that will be identified and decrease the mortality rate. The mortality rate of those who've been identified over age 70 and over 80 is especially worrisome and is substantially higher than those who are younger adults. We have not seen serious mortality in children, although we are seeing cases, as opposed to what we initially thought, there were substantial numbers of cases, pediatric cases in the 0 to 10 and 10 to 20 age group. The virus has a 1 to 14 day incubation period with an average incubation of about 5 days. It's spread primarily via respiratory droplet, which means close contact, usually within 6 feet. And in China, we've seen in some studies that as many as 20% of cases have no symptoms, which makes containing this disease and slowing it down particularly challenging. Major interventions have been put in place in countries which are experiencing serious outbreaks or epidemics of COVID-19. And I'm sure you all have seen in China, they took maximum measures to try and contain it, including lockdown of cities, closure of travel routes, closure of schools, closure of business. As many as 760 million people or more were at one point confined to homes. And in Italy and Iran, they've also taken fairly substantial containment efforts, including cancellation of mass gatherings, closures of schools. And as of last night, there were more than 300 million kids around the world that were out of school because of this virus. And then finally, closing with priorities that I believe are important for the U.S. at this point. I think we need to continue to substantially expand diagnostic testing. That has really changed over the course of this week. Now, 45 states out of 50 are reported to have the ability to do testing, and many hospitals will be coming online as well as they develop their own tests and get them validated. We also heard today news that Quest is moving to develop its own test, which is a promising sign because they have such large volumes of testing, clinical testing around the world, around the United States. And so I think the goal is to get to a point where any patient who has symptoms consistent with coronavirus can be tested quickly. We are not at that point now. We don't have the bandwidth to do that now, but that is the goal. I know that's the administration's goal, and state health labs, I think, are moving in that direction. We do need to do substantial work to get our healthcare system prepared for this virus. There are many hospitals that have done that work, but others, I think, have much more to do. In Italy and South Korea and Japan and China, we have seen that there's been major pressure already on the healthcare systems there. And we know that in the United States, if we see similar numbers of cases, which we will understand better in the coming weeks, that there could be substantial pressure on intensive care units to be able to take care of larger numbers than usual of critically ill patients. We also need to make sure our outpatient clinics remain available to patients. In China, we saw that cancer clinics and dialysis clinics have closed in an attempt to try and manage the virus, and that would be a really unfortunate secondary consequence of this disease in this country, which we need to avoid. And we also need to take very special care of our long-term care facilities. We've already seen in Washington State how terrible this virus can be within a long-term care facility for people who are most vulnerable. We need to support our public health agencies. They are now already working 24/7 to try to isolate cases, diagnose them, to quarantine people who need to be quarantined. If cases significantly rise in this country, it may no longer be possible to pursue the strategy that's underway now around identification of every case and quarantine of all contacts. It may become too large in scale for our health agencies to be able to do that. And at that point, we would need to shift to focusing on understanding the overall burden in the population, making recommendations to the public regarding isolation and testing, and possibly measures which we would call collectively social distancing measures, which might include closure of businesses or telecommuting, might include cancellation of large gatherings, and could include, in some places, closures of schools. Those decisions will probably need to be taken and be taken by local health officials with local political leaders and business and school leaders. And finally, a last word about medicines and vaccines. Vaccine development is likely to be 12 to 18 months away if all goes well. We've heard that consistently from the countries and internationally from vaccine scientists around the world. We should be developing plans for mass manufacture of vaccine when this vaccine is developed. Similarly, antivirals and monoclonal antibodies are being developed by a number of companies. Those could be developed far sooner in terms of the process of developing and approving those medications. And we will also need plans for mass manufacture of those medicines and hopefully in multiple places in the world as well. If the United States itself gets a new product, there will be enormous pressure from around the world to be able to access that product. So even though it's not usually done this way, we do need to think about making medicines and vaccines in multiple places in the world at the same time. It's great to see this kind of attention and attendance in this kind of meeting on the Hill, and I think the response has been very swift in terms of developing the emergency appropriations bill, and we're very excited that that is being aimed at hospital preparedness, public health agencies, the agencies of government that work with industry to make these important products. So I'll stop there and look forward to questions.
I have the technical capability to build this dashboard, but not actually open a PowerPoint presentation. Comforting. So what we're doing is we're tracking total cumulative confirmed cases of COVID all around the world. And we have here in this now global view, the red circles represent the total number of reported confirmed cases to date by region. And the region, the spatial resolution of the regions that we're reporting on differs depending on where
where we are in the world. So for instance, in China, we're reporting at the province level, at the US at the county level, Australia and Canada at the city level, and the rest of the world at the country level for right now. Over here on the left is a list of all the countries, and on the right is the deaths and recovered, which we're also reporting, and you can see the actual numbers by region. You can click on a location and it zooms into it on the map, and you also here can highlight the specific stats for that region. And then you can switch tabs here and you can see at the finer spatial resolution for that location. Another thing that we're highlighting is, in addition to the total confirmed cases, is the number of active cases at any point in time. And so this is the total number of cumulative confirmed cases minus the recovered, minus the deaths. And so this is really important because it kind of represents the better reflects the risk at any point in time. And I think what we'll see over the next few months is a shift of these kind of active cases from east to west. On the bottom right, we have a little timeline of the kind of temporal nature of this outbreak. And so here we're tracking the total cases over time, the total recovered over time, and the cases are broken down into cases within China and within mainland China and outside of China. You can switch tabs over here and see it at the logarithmic scale, so we can kind of exponential nature of the outbreak that we see at early stages. And then also we can track it at a daily scale in terms of the number of new cases or newly recovered cases reported on a daily basis, and you can kind of turn these off and on so you can see just one series. And what we're looking to do soon is disaggregate this red bar chart and split it between new daily cases in mainland China and outside of mainland China, because we've recently passed case where now have more cases outside China than inside China on a daily basis, which I think is a pretty critical shift in this situation. And then on the bottom here is a text box with a whole bunch of really important stuff that I think nobody reads. And it includes a link to the Lancet Infectious Disease article or letter that we wrote, which details the data collection protocol behind it and what the data sources are. There's a link to a mobile app and a link here to our blog, which details background about both the outbreak, the mapping efforts, and also some other modeling efforts that we're doing behind the scenes. And then a bit more about the data sources and some of the details about the map. So that's it for this. I think I should be able to get back to my slides now. Can you make these full screen over there? Oh wait, I can do it from there. Leave it. Thanks. Okay. And so, as I said, this is all actually hosted out of the Whiting School of Engineering at Johns Hopkins. And so one thing about where this data is coming from, in 2 minutes I cannot explain the details of the process behind this data collection, but what I can say is that it spans the entire scope of pure manual data input to purely automated data input, depending on the source, and also some combination of both. And so, for example, China data is completely automated and has been since February 1st, and is pulled from a particular website and updated every 15 minutes. At the moment, the US data entry is completely manual, and then the rest of the world is some combination between these two. Where the data is coming from is a variety of sources, and in general, it's based on it starts with the daily reports from WHO and the National Health Commission of the People's Republic of China, but those only come out every 24 hours. And so we use those kind of as a baseline, and then throughout the day we supplement with local level, city level reporting in reputable news and media outlets and local health departments as new cases come available, because obviously these are coming out at the city level first, so they're not able to be incorporated into these national level reporting reports that only come out on a daily basis or less frequent. And so to kind of instill confidence and validate this data, what we're doing behind the scenes is we're consistently comparing our data on the dashboard with the data provided by those WHO reports. And so that's what's shown in these two maps on the left. And so what we can see is that at any given point in time, we're always presenting more cases, as you would expect, because we have the cases that have at least always been reported previously by WHO, plus whatever the new cases are at the time. But what you can also see is that they follow the same trend. And so we are consistently reporting the reliable and I think accurate data. There are a few discrepancies. For instance, on the bottom, when Hubei province changed their reporting criteria and started reporting clinically diagnosed cases, there was a huge jump of about 15,000 cases reported that day. We captured it at the time. WHO captured it a few days later. And then on the right, on the bottom, is something that I think is really important and critical about this dashboard is